Hello there, everyone. Welcome to Decoding Respiratory Medicine, your ultimate destination for engaging and enlightening content in respiratory medicine. I'm thrilled to introduce you to a new videos of best choice questions in respiratory medicine. Be sure to subscribe to our channel and hit the notification bell so you never miss out on our latest release. Get ready to unlock your potential, challenge your mind, and embark an exciting quest for knowledge. Thank you for joining us on this remarkable journey. Let's dive into the world of best choice questions together. Question 1. 52 years old male is diagnosed with pulmonary arterial hypertension and is anxious about overall prognosis. Which of the following is associated with a favorable prognosis in pulmonary arterial hypertension? BMPR2 mutation, inhaled nitric oxide responsiveness, male, gender, older age at the time of diagnosis, systemic sclerosis. So question is about pulmonary arterial hypertension, good prognosis. Take your time. You can pause the video for 1 second and you can read the question again and try to think answer in your mind. I'm proceeding towards the answer. The answer is inhaled nitric oxide responsiveness. It is associated with a favorable prognosis in pulmonary arterial hypertension. Pulmonary arterial hypertension is a severe and progressive condition characterized by increased blood pressure in pulmonary arteries. Prognosis in pulmonary arterial hypertension vary widely and can be influenced by various factors. Inhaled nitric oxide is a vasodilator that can help assess the responsiveness of pulmonary vasculature. If a patient with pulmonary arterial hypertension positively responds to inhaled nitric oxide, their pulmonary arteries can dilate and adjust to treatment. This responsiveness to treatment is associated with a more favorable prognosis. The other factors listed: BMPR2 mutation, male sex, older age at diagnosis, systemic sclerosis generally do not predict a favorable prognosis. Factors like BMPR2 mutation, male sex and systemic sclerosis are associated with more severe forms of PH and poorer outcomes. Older age at diagnosis can also be associated with a less favorable prognosis due to potential comorbidities and disease progression. Inhaled nitric oxide responsiveness. Next question. A 23-year-old man presented to his GP with a cough following a flu-like illness. He has no documented history of respiratory diseases and has taken no medication. He admits to smoking cannabis daily. The GP discussed the long-term sequelae of smoking cannabis to encourage him to stop. Which of the following condition is most associated with long-term cannabis smoking? So this question is asking a complication of cannabis smoking. Is it ABPA, allergic bronchopulmonary aspergillosis, emphysema, IPF, idiopathic pulmonary fibrosis, LEMP, lymphangioliomyomatosis, or sarcoidosis? So you can take your time, you can pause the video, you can read question again. I'm discussing the answer now. So the answer is emphysema. It is the condition most associated with long-term cannabis smoking. Long-term cannabis smoking can lead to respiratory issues, and one of the well-recognized consequences in the development is emphysema. Emphysema is a type of COPD characterized by damage to the ear sacs leading to breathlessness, cough, and reduced lung function. Cannabis smoke contains harmful chemicals similar to tobacco smoke that can contribute to developing respiratory problems, including emphysema. The other conditions listed, ABPA, IPF, lemon sarcoidosis, are not typically associated with long-term cannabis smoking. Next question. 88 years old man is seen in respiratory clinic after a diagnosis of moderate pulmonary hypertension made on echocardiogram. Patient has a long history of atrial fibrillation, hypertension, and diabetes. He has been on warfarin for 16 years and also take a beta blocker and ACE inhibitors. He is an ex-smoker with no documented history of lung disease. In condition to pulmonary hypertension, his echocardiogram reveals biarterial dilatation and features of LV diastolic dysfunction. What is the most likely cause for his pulmonary hypertension? So you should know pulmonary hypertension classification to answer this question. Is it CTEPH, chronic thromboembolic pulmonary hypertension, congenital heart disease, cole pulmonale, left-sided heart disease, or primary pulmonary hypertension? Answer is, given the patient history of atrial fibrillation, hypertension, diabetes, and features of left-sided dysfunction, the most likely cause for his pulmonary hypertension is left-sided heart disease. Pulmonary hypertension caused by left-sided heart disease is commonly referred to as Group 2 pulmonary hypertension according to WHO classification. So the correct answer is left-sided heart disease. Group 2. Next question. 63 years old man present with a 6-year history of progressively increasing breathlessness. He is an ex-smoker with 60-pack year smoking history. He also has a history of systemic hypertension and atrial fibrillation. On examination, oxygen saturations are 85% on room air. Heart rate is 70 beats per minute. Heart sounds are quiet with a pensystolic murmur, audible and pitting edema to the mid-shin bilaterally. CTPA shows widespread emphysema and no evidence of pulmonary embolism. Echocardiogram shows elevated right ventricular systolic pressure of 60 with a moderate right ventricular impairment and tricuspid regurgitation. Which of the following is the most appropriate course of action? So this is 63 years old gentleman with a 6-year history of progressive breathlessness. He had a history of smoking, hypertension, currently hypoxic, sats are 85%. There is a pensystolic murmur with some features of heart failure, pitting edema. Echoes showing raised right ventricular systolic pressures with right ventricular impairment and TR. So what we are going to do next? Atrial fibrillation ablation, LTOT and optimization of airway disease, right heart cath, start sildenafil, or VQ scan to assess for distal CTEPH. Take your time to think for answer. And the answer is, given the patient history, examination findings and echocardiogram results, the most appropriate course of action is right heart cath. The patient's history of progressive breathlessness, history of smoking, clinical examination findings, elevated right ventricular systolic pressure, tricuspid regurgitation and pitting edema, and echocardiogram results of moderate right ventricular impairment all suggest the possibility of COPD-associated pulmonary hypertension. Right heart cath is the gold standard for diagnosing pulmonary hypertension and assessing its severity. This provides an accurate measurement of pulmonary pressures and cardiac output, helping to differentiate between different types of pulmonary hypertension and guiding a treatment decisions. While the other options might be relevant in certain situations based on the provided information, right heart cath is the most appropriate next step to accurately diagnose and evaluate the severity of pulmonary hypertension in this patient. Next question. 53 years old man suddenly become breathless on the ward 5 days following hip surgery. He is tachypneic 30 breaths per minute, tachycardic 130 breaths per minute, and require 10 liters of oxygen to maintain an oxygen set of 94%. His peripheries are cool and a manual blood pressure reading is low, 85 to 55. CTPA reveals a central saddle pulmonary embolism with a clot seen in his IVC. Which of the following would prompt a treatment with thrombolysis? So in this case, you should know pulmonary embolism and when to thrombolyze patient. Blood test revealed a raised troponin and BNP. When there is a hypotension, when there is increased oxygen requirement, when the site of pulmonary embolism or the size of pulmonary embolism. Take your time to think. Answer is hypotension, as in this case there was a low blood pressures. Hypotension would prompt a treatment with thrombolysis in the context of pulmonary embolism. Hypertension in the setting of a pulmonary embolism indicates a more severe condition known as a massive or high-risk PE, where there is a substantial obstruction of pulmonary circulation that leads to compromised cardiovascular system. This situation poses a significant risk of hemodynamic collapse, shock, and death. Thrombolysis is considered as a treatment option to rapidly dissolve the blood clot and improve blood flow in this critical situation. The other factors listed may influence the overall assessment and management of patient with PE, but hypertension is a key factor that strongly indicates the need for aggressive treatment like thrombolysis. So the correct answer is hypertension. Next question. 55 years old lady who has never smoked present to acute medical intake with a worsening shortness of breath and dry cough for 6 to 8 weeks. She has had a low-grade fever and felt systemically unwell. She has no travel history of note, has not been in contact with anyone unwell, and is on no regular medications. Her husband has recently acquired a pigeon. A diagnosis of HP is suspected and investigations are requested. Which statement regarding HP is most accurate? Bronchoalveolar lavage shows neutrophilic inflammation. Positive serum precipitin is diagnostic for this condition. It is more prevalent in smokers. Removal of the inciting antigen is the most critical aspect of long-term management. The condition invariably progresses with a poor prognosis. So in this question you should know about HP and certain factors related to HP. Think about the answer and we will discuss the answer in next video.